All right, and thanks to Dr. Schroeder, who kindly shared some radiographs and slides. So, we all get patients referred from the ER, and it's helpful to kind of get into the ER mindset about how they think about hand injuries. I mean, pretty straightforward. There's lacerations, soft tissue injuries, amputations, infections, fractures, dislocations, maybe high pressure injuries, and burns. And then now, how do we as hand surgeons think about ER hand injuries? Well, for us, it's about what we're going to do, right? Is it an emergency? Is it urgent? Do they just need urgent follow-up or non-urgent follow-up? An emergency is basically what's going to get us out of the bed at night and head into the hospital. Urgent things are, what are we going to add on for the next day? What's going to change our day tomorrow? And then, urgent follow-ups, what do we need to overbook into our clinic, even though we're already seeing 30 patients, we need to get them in and see them, and then routine follow-ups. So emergencies, necrotizing fasciitis, compartment syndrome, obviously replants, revascularizations, dysvascular hand, fingers, and high-pressure injection injuries. Urgent cases that can be added on the next day potentially, some open fractures, septic arthritis, spaghetti wrists, assuming that all the digits are well perfused. Urgent follow-ups, scaphoid fractures, any operative fracture, tendon and nerve injuries, and certain types of wounds and lacerations, and then routine follow-ups, or even PCP follow-ups, felon, paronychia, abscess, although in our clinics they all tend to come to our hand clinic, all of these things. Nothing is followed up with just PMD. Fingertip crush injuries, triquetral avulsion fractures. All right, so things that we see missed very commonly, and they're usually dubbed with terms like this: wrist sprain, finger sprains, non-displaced fractures, or simple or superficial lacerations. When you see those things as a hand surgeon, your index of suspicion should just kind of click in the back of your mind, or when residents are presenting cases to you or trainees, just always keep in the back of your mind. This is why we review cases and go over the images with them, because sometimes these diagnoses can hide something a lot more serious. So let's look at that. So wrist sprains, a lot of times, as Dr. Vogeli went on at length, can hide scaphoid fractures. Scapholunate injuries, also very commonly missed, particularly in the setting of distal radius fractures. Perilunate injuries, you would think, should be easily diagnosable from the plain films, but surprisingly also, very commonly missed, especially at outside facilities and when they're referred back in. Also, DRUJ injuries and dislocations can easily be missed as well. Under the category of finger sprains, we have things like jersey fingers, which, all of these, sometimes they're obvious and sometimes they're not obvious. With type 1 jersey, you don't have a big bony fragment there, and the tendon can be pulled all the way back down, so sometimes that can be easy to miss. Mallet fingers, if it's a huge bony mallet, most of the time that should be pretty visible on the x-ray, but then you may have non-bony mallets that can be missed as well. Central slip avulsions, sagittal band ruptures, and ulnar collateral ligament, radiocollateral ligament injuries. All of these things can be missed or just kind of misdiagnosed as a simple sprain. And then you've got quote unquote, non-displaced fractures. Some of those can end up being CMC fracture dislocations, and CMC dislocations can be missed entirely. And then there's some pediatric finger fracture issues that I'll talk about at the end as well. Simple lacerations, superficial lacerations, you always have to investigate a little bit further. And I always tell our trainees and our residents that when you're in the ED evaluating, say, a dorsal finger laceration, don't just kind of mindlessly wash it out and close the skin and send them to clinic. I mean, that's the best time to figure out if there's an extensor tendon injury, and allow appropriate planning for later on. All right, so we can talk a little bit more about kind of this wrist sprain category. I think we've already kind of gone over scaphoid fractures at length, but very commonly you can have an occult scaphoid fracture That's why we get serial films, especially if there's a high index of suspicion. But the exam needs to be good, needs to identify snuff box tenderness and identify those patients where there is a higher index of suspicion so that we can either get advanced imaging or get follow-up x-rays in 1 or 2 weeks after mobilization where there might be some resorption at the fracture line to make it more clear. Scapholunate injuries, if they all look like this, I think it'd be pretty easy, but unfortunately, they don't. So these can be missed pretty easily. Dynamic injuries like this one may look normal on a plain film. You may not even see significant dizzy deformity, but as is shown in the bottom, 2 images, when you clench your fist and put a strain, that translates force through the midcarpal joint via the capitate to the scapholunate interval and can widen and demonstrate a dynamic instability there, which needs to be picked up on. So things that we can see on imaging that can help identify scapholunate tears. Well, there's the obvious like big Terry Thomas signs. There's a cortical ring sign that you get from the scaphoid going into the flex position. And then there's the dizzy deformity with lunate extension and scaphoid flexion. So, when we're talking with our trainees and residents and teaching them, these are all the things we need to help them identify. Also looking at the scapholunate angle here, normally between 30 and 60 degrees, how to identify the, distinguish between the lunate and the scaphoid and the other carpal bones on the lateral x-rays. For the interns and the juniors, it's not always very straightforward and it's hard for them to see this. So this is what we have to work on with them. Perilunate injuries from an AP point of view, and I still sometimes get, a text from a resident with a screenshot of just an AP view of the hand, when they're staffing a consult with me, and we have to review that, just one AP view, one view is never enough to fully evaluate. So you have to get the AP, the lateral, and the oblique. So here you can see. Now, even from the AP view, if you're looking closely, you can see that the glueless lines are not lined up appropriately in that AP view. But when you look at the lateral view, it's pretty clear that there's a perilunate dislocation here. Sometimes the lunate is all the way pushed out into the carpal tunnel. Oh, let me go back here. And then here's another one, courtesy of Dr. Vogeli. So here's one that also can be missed as well, DRUJ dislocations. So on the lateral film, you can see that there's actually a volar displacement of the ulna there. So, and things are also not lining up clearly on the AP, but sometimes these things are missed by the radiologist and by the ED physicians. So we have to keep a high index of suspicion. The quality of the imaging is very important and has a lot to do with sometimes with these injuries getting missed. So we should not settle for mediocre imaging, even though it's painful to send someone back and ask them to, redo an X-ray to get a true lateral or the imaging that we want. But we really shouldn't settle for mediocre imaging. Like for example, this patient, you can see read by the radiologist, no acute fractures or malalignment, no evidence of dislocation. But when you get the small finger out into a clearer view where it's not overlapping with all the other fingers, there's pretty obvious, base of middle phalanx fracture dislocation there. So, how do we identify, so first you have to know what is how do we identify that the radiograph is a good radiograph, and I think we're all familiar with this, but when you're concerned about, say, a DRUJ dislocation, the landmarks that you can use are the pisiform, as we discussed in our workshop, earlier today. So if you've got the pisiform should be between the volar border of the scaphoid and the capitate, and if you divide that distance up into thirds, it should actually be kind of in the 2/3 of the way from the capitate to the tip of the scaphoid there. So that helps you identify whether you have a good lateral view. On the AP view, you'd like to see the interval between the radius and the ulna, but and also other landmarks are that you want the ulnar styloid to be on the ulnar side of the ulna, and then the ECU groove should be radial to the midpoint of the ulnar styloid. Okay, and then I mentioned Gilula's line, so that's another good landmark that we should all teach our residents and trainees to be on the lookout for, so that we can identify things like perilunate dislocations or other carpal instability, even on the AP views. And we kind of already discussed axis of the carpal bones and calculating the scapholunate angles. Okay, and then just another view of that shot where you can see that the lunate is not in its typical appearance pattern, even in this AP view. Okay, so CMC dislocations or CMC fracture dislocations. Yeah, so these are also very easily missed on the AP view. It looks, you know, you can imagine how, you know, someone in the ED could look at that and not really pick up on it. Even from some of the lateral views, if they're kind of off, you can get overlapping of the carpal bones and sometimes not be able to see that apparently. On the CT scan, though, on the right side, you see it's very clear. So these are all things we have to be on the lookout for. Here's another one. Your eye is drawn to the ring finger metacarpal fracture, so you have to be careful when there is an obvious injury not to miss the more non-obvious injuries. So, you know, the fifth metacarpal CMC dislocation could easily be missed on this one as well. Hook of hamate fractures, not obvious, you know, more your suspicion should be raised based on the history and then the physical exam and the location of their pain. But, you know, getting this sort of carpal tunnel view plain film can help visualize those. So finger sprains, we already discussed kind of mallet finger, jersey finger, also volar plate avulsions and central slip injuries. And as I mentioned, you know, when there's a bony mallet, it's usually pretty obvious, but when there's a non-bony mallet, those are things that can get missed, and then the patient ends up spending time between the ED and whenever they make it into your clinic without being splinted, and then that's time wasted, or it might be missed completely, and then they come back with a long-standing chronic deformity. Same thing with jersey fingers. You know, the finger looks straight on the x-ray, so if there's not that obvious kind of bony fragment right there, then that might go missed as well. So pediatric injuries, particularly Seymour fractures, this is one I really hate to see when they come in late, and I've seen several of them being referred from even a children's hospital ED, where there's you know, a Salter 1 or 2 through the physis, and the ED sees it. They see that the nail plate's, you know, out, but it's more or less intact, so they just bandage it up, send them home, and then they come back 7 days later, either to the ED or into the clinic with a finger with cellulitis or even pussing out, and that's a real problem. So these need to be treated very urgently. And here's another example of an 18-month-old who had a dog bite to the index finger. Let's see. Yeah, this was the yeah, here is the plain films on that one. So it's hard to even visualize the epiphysis on the distal phalanx at this point with this young of a patient, but you can see that the distal phalanx is quite dislocated there. So there's the risk of entrapment of soft tissues within the physis, and that's not gonna, and it's an open injury. So if it's untreated, it has a high incidence of going on to osteomyelitis. Unfortunately, this particular patient was delayed. It was more than a week before they made it in to be treated. So we had to open it up and extract the soft tissues from that, from within the physis, and then pin it, and the patient ended up doing well. So that's all I got for commonly missed injuries. Thanks, everybody.